Good evening, everyone. It's wonderful to see you all. I see a lot of good friends here that have come before, but we always like to ask how many of you are new this time? All right, well, welcome to the first of 4 sessions this year addressing Alzheimer's disease. Just before we get started, just wanted to mention one logistical issue. The lecture is going to continue till 7 o'clock. So if you need to get up and use the restroom or want to get a glass of water or need to stand up, the restroom's right behind that wall along with the food. So we're going to go ahead now and get started. And the first thing is to make sure I can make this pointer work. Oh, very good. So today we're going to talk specifically about Alzheimer's disease and the other dementias. We hope to help you understand the various types of dementia that your loved ones may be experiencing, the differences in the symptoms and how they present, and also the progression from normal aging to dementia. In June, we'll be back, and in June we'll talk about treatment. What are the currently available treatments for Alzheimer's disease, and what do we see in the horizons? We all know that medication can only do so much for people with Alzheimer's disease and other dementias. So in September, we're going to talk about behavior and communication strategies, how you as a caregiver need to adjust your style in relating to a loved one with dementia. And finally, we're going to talk in November about what we know about reducing risk for Alzheimer's disease at this point. So this is always just a fun one, just to make sure you're awake, get you going, see if you can identify these pictures. Now, some of you may have seen these pictures before, so you can't give it away to the new folks. So we start easy up here. Ronald Reagan, move across. Shriver, I heard it. All right, how about we'll just go straight across. Who's that? Jack Lord, I heard it. We'll skip her a minute. Who's this? Yeah, very good. How about this one? Up here on the right. Malcolm, you want to give a cue?
Edmund O'Brien, that's correct.
Whoops, backwards here, sorry. Edmund O'Brien. And then we go down. Who's that?
Dana Andrews.
Yeah, you always close, good. Columbo, yeah, Peter Falk, that's right. Go down this way. Who's this? Arlene Francis. We got close. Next to Arlene Francis.
She wrote a daily column, advice.
Yeah, Ann Landers. Her real name was Pauline Phillips. Down here, who's this? Star Trek. Yeah, that's Star Trek. Who? Scotty? Who is Scotty? Do we know who Scotty is? Even I have to look up his real name. So Malcolm?
James Doohan.
Doohan, okay. I just know him as Scotty. So, and right here, Rita Hayworth. That's a little bit easier. Going over. And then here. A painter, famous painter. Yes. Up. Right. Over. Very good. And David Niven. Okay. Down. All right. One more, last one over here.
Very good, Gene Barry.
Yeah, now there's 2 I just skipped because the only 2 that are still alive are these 2 right here. So who's this? Yeah, Glenn Campbell. And then here? Yeah, the basketball coach, Pat Summitt. So you can see that Alzheimer's disease and the dementias don't leave anybody spared. So Alzheimer's disease is one of the most feared diseases. In fact, it's the second most feared disease in the United States. after, heart disease and cancer, second most feared disease after cancer. It's more feared than heart disease, stroke, or diabetes. And that's very significant, how much fear we have of the disease. That contributes to us not identifying it or treating it as early as we'd like to oftentimes, because there's still a stigma associated with it and a fear. And in fact, in an international study that looked at Alzheimer's disease or feelings or beliefs about Alzheimer's disease in France, Germany, Spain, and the US, about 25% said that they feared Alzheimer's disease more than, listen to the list, cancer, stroke, heart disease, diabetes. They feared Alzheimer's disease more than the flu and depression. So that is a powerful statement about the stigma that's still associated with this disease. And a third of older adults in the US fear the disease more than other conditions. So here are the statistics today. We know that 5.2 million Americans have Alzheimer's disease. Those are the latest statistics from 2013 from the Alzheimer's Association. I always think a remarkable fact on this slide is that there's 15.4 million caregivers. So if you do the math, there are 3 close family members or friends involved in the care of every one individual with Alzheimer's disease. Alzheimer's disease has a tremendous cost to our nation, $203 billion just in direct care costs alone. So that's Medicare reimbursement, for example, doctors, and long-term care. That doesn't at all incorporate all the costs and all the hours that are provided by family caregivers who provide the majority of support for people with Alzheimer's. And today, someone develops Alzheimer's every 68 seconds. By 2050, that'll be every 33 seconds. We're going to come back to the statistic there about Alzheimer's being the 6th leading cause of death. This is just another way of portraying this particular escalation in the cases of Alzheimer's disease. This is what I just described, from about 5.2 million people to 2050 at over 15 million people. What's interesting about this chart is that we see the greatest growth in the number of people with Alzheimer's is in that 85 plus population. And so the 85 plus population is the blue line, and you can see how that increases, while the red line, people 75 to 84, plateaus out eventually. And approximately the same percentage of people, 65 to 74, have the disease. So we're going to have a lot of people with Alzheimer's disease that will not only have dementia, but they have a lot of other conditions and are very frail.
Let's focus down on just California. And 1 in 10 Alzheimer's patients in the United States lives in California. That's probably because California is the most populous state. Doesn't mean living here is going to give you Alzheimer's disease. In Orange County, the estimates are that 75,000 individuals either have Alzheimer's disease or are at risk of developing Alzheimer's disease, meaning they have mild cognitive impairment, which we'll talk about. And in the baby boomer generation, these are individuals born right after World War II, 1946 to 1964, 1 in 8 individuals will develop Alzheimer's disease. And 1 in 6 baby boomers will develop some form of dementia, be it Alzheimer's or Lewy body or another type. Currently, the number of Alzheimer's patients in California is somewhere over 600,000. But within 15 years, essentially by 2030, it's estimated we're going to almost double that to 1.2 million Alzheimer's patients, just in California alone. Most of these, as you can see from the chart, are going to be individuals over the age of 75. Will have essentially a doubling of the numbers, but also those people who are younger than 75, we're also going to see essentially a doubling.
So one of the questions that a lot of us have are we personally at risk for developing Alzheimer's disease? And while we're going to talk a lot more about that in our November session, we did want to point out today that the greatest risk factor for Alzheimer's disease is growing older. That this chart graphically illustrates that the percentage of people with Alzheimer's disease doubles every 5 years after age 65. So we have 5% of people affected at age 65. By age 70, we have 10%. By age 75, we have 20%. And by age 85, we have up to half of individuals affected by Alzheimer's disease. So it has a strong correlation with growing older. And, you know, why do we see so many people with Alzheimer's disease? Because today we live into the age brackets where we're at greater risk for the disease. If I had been a white woman in 1940, I would have lived into my early 40s. Today, as you can see here in Orange County, as a Caucasian woman, I'm going to live to be 82.2 years old. According to the last chart I showed you, 15% of people at age 80 are having Alzheimer's disease.
Well, the numbers are going to increase across all ethnic backgrounds, not just Caucasians, but Hispanics are the second most common minority, the second most common group in California. And data from 2010 Alzheimer's Association suggests that by the year 2030, there's going to be a tripling of the number of Hispanic Latinos with Alzheimer's. There's also going to be a tripling of the number of Asian Americans and a doubling of the number of African Americans. Why might that be? Well, there's some common factors that sort of carry across all of those different ethnicities. One of them is that we know that Alzheimer's disease, one of the risk factors is cardiovascular health. And so the Asian, the Hispanic, and the Latino all have higher incidence of some of the cardiovascular problems like hypertension and diabetes than do Caucasians. Also, within the Hispanic population, we know that education is a preventative factor. So the more educated you are, the lower the risk of developing Alzheimer's disease. And in California, essentially 1 in 10 Hispanics have only completed 8th grade education or less. So there's a large number of individuals with limited education, and that also places them at that increased risk for developing dementia. Cordula mentioned a moment ago about mortality. And the earlier slides had said that Alzheimer's disease is the 6th most common cause of death across all age groups in the United States. And that was reported by the Center for Disease Control and Prevention, the CDC, in 2010. And they attributed about 85,000 deaths per year to Alzheimer's disease. Well, one of the interesting things they also noted in the next slide is that the percentage of Alzheimer's patients, the percentage of individuals dying from Alzheimer's disease since 2000 to 2008, the data that they looked at, has increased by about 66%. A lot of other causes of death, including heart disease, cancer, stroke, HIV, etc., those are all showing a decline, a decreasing frequency as a cause of death. So Alzheimer's disease is increasing. A lot of the other common causes of death are decreasing. And just recently, in fact last week, there was another study released that shows that the CDC may actually have greatly underestimated Alzheimer's disease in terms of attributed to be the 6th leading cause of death. In fact, what they did is they the authors of this study, they were sort of concerned about the fact that often it's very difficult to attribute a cause of death to Alzheimer's because many times there'll be other causes also present when the person dies. So for example, if someone who's been in a nursing home for the last 5 years with very severe Alzheimer's disease dies, the death certificate might list the primary cause of death, which might be something like pneumonia or heart failure. And Alzheimer's might be listed somewhere along there as a contributing factor. Well, they wanted to actually do a more rigorous way of analyzing Alzheimer's as a cause of death. And so they looked at 2 large studies, which many of you might be familiar with. One is called the Religious Orders Study, or the Nun Study, that has been tracking Catholic sisters, priests, and brothers for a good number of years. And the other is a large study done in Chicago. And together, when you added the 2 studies together, they had about 2,500 older adults who were all normal at the start of the study, and they looked at them over a course of a number of years, on average 8 years, and they found about 22% died. And the 22% died, about 78% had Alzheimer's disease. So they actually looked to see what percentage of the people who died from that group of normals we could attribute Alzheimer's disease as a major cause. And what they found is that when they extrapolated from their study to the nation, that instead of 85,000 individuals dying per year from Alzheimer's, they estimated that it was over 500,000. And what that would do is, if you took this bar, it would actually be the 3rd most common cause of death after heart disease and cancer, not the 6th most common cause of death. So that's very important because now it sort of gives a much more accurate picture of the actual cause of death for most people in the United States. And Alzheimer's isn't one of the top 10, it's actually the top 3rd.
All right, so now we're going to talk about the course of Alzheimer's disease, meaning from normal aging all the way into Alzheimer's disease developing and progressing. And so in order to do that, we just need to start with making sure everybody in the audience understands these terms. Some of you are already very familiar with them and have heard me give this little explanation before, so please be patient while I explain it for everyone who hasn't heard it before. But it's very important to understand the difference between the terms dementia and Alzheimer's disease. So dementia refers to a syndrome, and it has 3 different characteristics. Those 3 characteristics are that there's a loss of intellectual functioning, that number 2, it affects memory, plus 1 or more other cognitive abilities, so that might be language, reasoning, judgment, visual, spatial skills, and the impairment is so severe that it interferes with your abilities to do your everyday living skills. At first, it interferes with work and driving and then cooking and dressing, and then eventually, you know, things like toileting yourself and so forth. So that's what dementia is. But dementia is an umbrella term. There's a lot of different causes of dementia. So it's good to think about the term dementia as similar to the term cancer. Cancer is a big umbrella term, and we could come up with a list of many, many cancers: lung cancer, breast cancer, prostate cancer, cervical cancer, and so on and so on. The same thing with dementia. It's the big umbrella term. There's many types. It just happens to be that Alzheimer's disease is the most common type. And we also know that you just don't go from normal aging to Alzheimer's disease like you're falling off a cliff. There's a progression. Now we understand that there's a gray zone or a borderland between what we consider normal aging and Alzheimer's disease. And that borderland, the gray zone, is called mild cognitive impairment. And we're going to describe that for you a bit more in a few minutes.
So I think it's important, in order to understand a little bit more about Alzheimer's and the effects on the brain, is to have a little bit of an understanding of the brain. And this is a cartoon of the brain, and it's in a real brain. If you've ever actually looked at a brain or had an opportunity to go through like one of our tours where you can actually get a chance to look at brains and hold a brain. A real brain is about the size of a medium cauliflower that you could hold in the palm of your hand. And it would probably weigh about 2.5 to 3 pounds. And although if you think about 2.5 to 3 pounds is a relatively small proportion of our total body weight, the brain is a very complex structure in that little organ. It's estimated we probably have between 70 and 100 billion neurons. And each neuron can actually connect to as many as 7,000 other cells. So when you look at the number of connections, it's on up there in the trillions of connections. There's a number of areas that are very important for Alzheimer's disease. A person's ear would be right about here, and if you went into the brain a little bit above the ear, you would hit this side structure called the temporal lobe. And there's a particular organ within the temporal lobe. It's sort of about the size of someone's little finger, and it sort of extends all the way through the middle of the lobe, and it's called the hippocampus. And the hippocampus is the crucial part of the temporal lobe for the encoding and processing of new information. And this is an area that's affected very early in Alzheimer's disease.
So we'd like to start just by talking about normal aging, some of the characteristic changes, and all of these slides that you'll be seeing have on the horizontal axis the time in years, and then on the vertical axis represents cognitive decline. So the way this is set up, this top line represents a healthy younger adult. And this first slide just shows us that in normal aging, all of us experience some slight changes. So things like having more difficulty coming up with a word sometimes. I wouldn't be surprised if sometime during this lecture I have a word finding problem, and then maybe an hour from now I'll think of that word, right? Have you ever had that happen? And a lot more difficulty remembering names, right? When you get a little older, you have to start being not embarrassed about asking people, now, what was your name again, right? It's just a little tougher to do that. As we get older, we get more distractible, so I always like to tell the story when I grew up on a little farm and we were quite poor, and so my desk was actually in our living room area, so I would study there, and my brother would watch TV there, and I could zone everything out. I could create my own room and study quite effectively. If you asked me to do that today, I wouldn't get a whole lot done because I'd be too distracted by the outside noise or the television. So it's a little harder to recall information. It also becomes a little bit more difficult to multitask. So all of us are going to experience those changes as we age. So we're going to talk about, in comparison to that, what's the difference when somebody starts to develop mild cognitive impairment?
So one of the big changes in Alzheimer's disease is that I think probably over the last 5 to 7 years, the concept of Alzheimer's disease has altered quite radically, where now we talk about Alzheimer's disease going through 3 different phases: a preclinical or asymptomatic phase, mild cognitive impairment, and then the dementia phase. And these phases take place over a very long, extended period of time. In fact, the changes that go on in the brain during the preclinical phase probably are taking place decades before any overt cognitive symptoms or changes are evident. During this preclinical phase, what it is, this is a phase or part of the continuum where the individual could be either absolutely no different from their healthy peers, or there could be very subtle cognitive changes. These are not necessarily significant, but they're noticeable to the individual. And during this preclinical phase, what is happening is there's certain biological or molecular changes happening in the brain that we aren't able to view true through traditional types of imaging techniques, but these are sort of very small molecular changes, and one of the most common is an accumulation of an abnormal protein in the brain called beta amyloid. And we're going to talk about some new techniques for scanning or identifying beta amyloid in a little bit later, but this beta amyloid is starting to accumulate in the brain, and it's accumulating many years, even decades before any symptoms occur. Okay. Go ahead.
So it's always a little amazing to me to think about the fact that, you know, I'm 59 and I could have Alzheimer's disease and not know it. And that's what Malcolm's really saying, because it's silent for such a long, long time. Now, when we do look at the brain at death, that's what these pictures are of. We see at autopsy, when we look at the whole brain, compare a person who's normal versus one who's has Alzheimer's disease, and this is a side view of the head. You can see that in this normal brain, all the gyri, or the hills and the valleys, are nice and tight, compact, whereas that's not true in the Alzheimer's brain, where there's a lot of atrophy that has occurred. And we can see that that atrophy is pretty significant down here in the temporal lobe, where that structure of the hippocampus is that Malcolm's referred to. And in this particular brain, we also see atrophy in the frontal lobe and in the parietal lobe. When we look at the tissue microscopically, this is what a healthy individual's tissue would look like, brain tissue would look like. This is the person with Alzheimer's disease. And so now we're going to show these just a little bit more close up to show you what the plaques and tangles look like. And so here you can see these are the senile plaques, right. It's 5:30 or whatever time it is. And they look like Brillo pads, don't they, a little bit? They're actually sticky, clumpy accumulations of this abnormal protein, beta amyloid, that Malcolm was referring to a moment ago. Accumulate around the outside of the cell and really suffocate the cell. And you can see break down the connections between the cells. So these are tangles, and those look like flame-like projections. And they consist of another abnormal protein that breaks down inside the cell and basically turns into twisted threads or filaments and destroys the cell from the inside.
The idea of biomarkers being a major contributor to Alzheimer's disease isn't new. In fact, biomarkers are often discussed in many other diseases. So for example, just take heart disease and stroke. We know that, for example, heart disease and stroke is due to an accumulation of cholesterol, or particularly the bad cholesterol that starts to block the artery walls, and then over time it sort of causes a blockage and you can have a heart attack or you can have a stroke. Now those are due to molecular changes in the body or the brain. They're silent in that we really can't observe it. There may be no evidence ahead of time of the stroke or the heart attack there was anything really wrong. But then suddenly the accumulation of all of those things over the years causes an event to occur. The same thing is true with Alzheimer's disease. We have an accumulation of the beta amyloid and tau in the brain, and then over time, with this increasing accumulation, more and more, eventually we'll start to see cognitive symptoms occur. This is a graph showing, it was made by individuals at the Mayo Clinic in Rochester, Minnesota in 2010, and it was just recently updated. But what it does is it shows the sequence in which biomarkers play a role in an individual's progression towards Alzheimer's disease. And it sort of shows a timeline when these things start to occur and how they change over time. And there's a number of ways we can measure biomarkers. And these are relatively new in the field of Alzheimer's disease. One of them is by looking at your cerebral spinal fluid. And the reason we do that, let me just get my half a brain here. That's the nickname my staff give me too. But here we have sort of a model of the brain. And in the middle, you'll notice this cavity. This is called the lateral ventricle. And cerebral spinal fluid, which is sort of the consistency of a clear liquid like water, is produced in the very back of this lateral ventricle, and it's sort of pumped into the ventricle, and then it sort of flows out through various canals around the spinal cord and around the brain. So this fluid is constantly being reproduced in the brain. It's flowing around the cells, and by going in at the base of your spine, we can sort of draw out some of that spinal fluid. And because as the cerebral spinal fluid has sort of gone around the brain, it'll pick up some of that beta amyloid and tau. And by measuring the levels in a normal adult and comparing it to somebody who maybe is at risk for Alzheimer's disease, what we typically find is that the levels of beta amyloid in the spinal fluid are low. The reason for that is the amyloid is being stuck in the brain in these sticky descriptions that Cordula just finished talking about, the plaques. So we'll often see a lower level of beta amyloid in the spinal fluid than what we would see in a normal adult in someone at risk for Alzheimer's. Now, when do these changes start to occur? And this is what that graph shows. Way out here, this is a person who's still normal, and it's estimated this change is occurring maybe decades before any clinical symptoms are present. So in an individual who's still functioning normally, there's starting to be changes in the spinal fluid. And also, if we do another kind of a scan, which is just recently approved by the FDA, which we'll talk about in a little bit, called an amyvid or amyloid scan, we can see accumulations of amyloid in the brain many decades before the person actually starts to develop any symptoms. Later on, we can start to see changes in other types of biomarkers or other types of indicators of cognitive impairment. This yellow line is changes seen on an MRI scan or a PET scan, and you can see they occur quite a bit later than do the changes in amyloid, either through CSF or amyvid. One recent study, go to the next slide. One recent study, you might ask, well, how do you know that they're occurring decades ahead of time? Well, I don't know if any of you have heard of a study, it's called DIAN. That stands, it's for it's Dominantly Inherited Alzheimer's Network. And what it is, it's a program, it's run out of Washington University. And what they're looking at is they're looking at individuals at very high risk of developing Alzheimer's disease who have primarily a genetic or a familial cause of their disease. Familial Alzheimer's disease, where you have it due to a particular gene, is really quite rare. Probably 95% of people with Alzheimer's do not have a strong family history. But there's a small percentage, 3 to 5%, who have a familial form where it's due to a particular abnormal gene. Typically, it's either a presenilin or what's called an amyloid precursor protein gene. But what they're doing is they're looking at offspring of individuals who have this familial form of Alzheimer's disease, and they're looking at the CSF, the spinal fluid, and they're doing these imaging to look at accumulation of beta amyloid. Now, what we know from a lot of research is that if you, for example, have a parent who carries this abnormal gene, you have a 50-50 chance of developing Alzheimer's disease. So if your parent had one of these presenilin genes, you have a 50-50 chance of also developing Alzheimer's disease. And typically you develop that at a young age, in your 40s, 30s, 40s, and 50s. the age in which the offspring develops Alzheimer's disease is generally very similar to the time the parent developed the disease. So if the father developed it at age 42, say the son who carries the gene is also likely to develop it at age 42. So what they've done is they've looked at people who are much younger, who do not have Alzheimer's disease or any cognitive impairment, but they have this high risk, and they've looked at the amyloid in either scans or in the fluid, CSF. And what they found is they can see changes 25 years in these individuals at high risk who are still functioning normally, and it would be expected that 25 years from now, let's say that person would reach age 42, but they're seeing changes in that person who's just in their late teens and early 20s. So this is sort of a very radical discovery in the sense that we know that Alzheimer's does not occur over the course of just a couple of years. You don't suddenly get it. It's something that has been developing in the brain for decades.
So one thing I wanted to say is some of you here in the room are UCI Mind research volunteers, and we need to thank these volunteers because many of them are donating CSF so that we can do these kinds of studies and look at the changes in the cerebral spinal fluid and be able to identify the disease earlier and hopefully also treat the disease earlier. So I want to acknowledge all those good folks out in the audience who are helping us out in that way. So in these preclinical stage that Malcolm's been describing where the disease is silent and we might have some changes in the biomarkers like the CSF. Generally what the person's experiencing, either they're not experiencing any changes, they don't have any complaints, but some individuals have a sense that there's some changes going on. They have what we call subjective memory complaints. Things like they seem to be forgetting names, missing appointments, misplacing items. But when they go in and they get cognitive tests, they still score in the normal range. So I would still score in the normal range for someone 59, even though I thought that my memory was worse than other people's memories. And this period of time can actually last up to 15 years. Now, what's really important is that to recognize is that these kinds of cognitive symptoms can be due to a lot of different conditions. So they could be due to depression, to anxiety, to medical conditions, and if there's a concern, the doctor should be ruling out all these possible causes. Just because you feel like your memory might be not as good as someone else's doesn't mean that you have Alzheimer's disease or going to be developing full-blown Alzheimer's disease.
Now, eventually, as the pathology occurs in the brain, that individual will show more cognitive problems, and they may go into the next stage, which is the mild cognitive impairment stage. And this is a stage where it's not just the individual who's noticing the change, but now other people, their friends, their family, their colleagues, are noticing the change in the person's memory or cognitive abilities. So at this stage, the symptoms are really occurring that are obvious to other people for the first time. And typically in a neuropsychological testing situation, an individual would score in the bottom 10% of their peers on, say, tests of memory or other cognitive abilities. MCI is a very heterogeneous condition in that it has can have very different features, which we'll talk about in a minute. It can have different etiologies or causes. So MCI is just really saying that there's some symptoms of cognitive difficulties that are beyond what you would expect to see in a normal adult, yet the individual is not significantly impaired, such as in a dementia, where they can't function, they can't do their everyday living skills, they can't shop, they can't pay their bills, they can't manage their appointments. The individual with MCI is still able to do that, but there's definitely a problem going on. Now, one of the interesting things about MCI is that although a majority of them probably 50 to 60% will likely go on to develop a dementia. Some will actually stay the same. And in our clinic, we have some MCI patients who've been with us for 7, 8, 9 years, and they still have MCI. They haven't really gotten worse. And there's a smaller group, maybe 20%, who actually get better. And they go back to being normal. And sometimes they might sort of flip back and forth from normal to impaired, but they're not necessarily progressing.
So even though Malcolm gave you that caveat that there's many different causes for MCI, we do know that MCI greatly increases your risk for developing Alzheimer's disease, and that's what this slide illustrates. So only over 4 years here, 48 months, if you're a healthy older adult, cognitively normal, only about 1 to 2% of those individuals develop or do what we call convert to Alzheimer's disease directly. But if you have been diagnosed with MCI, you can see over this same period of time that a large percentage of individuals convert to Alzheimer's disease. Actually, about half of them, about 40 to 60% of the individuals with MCI go on to develop Alzheimer's disease during this period.
I mentioned just a moment ago about the heterogeneity in MCI. And we now sort of divide MCI into a number of different subtypes. The most common ones are where an individual has an amnestic or a memory problem, and they don't really have deficits in any other type of disorder. Their language is okay, their visual spatial. There's also a type that is called amnestic multiple domain, where they have not just a memory problem, but they have deficits in other areas like their language or their reasoning or their visual spatial abilities. These two types of amnestic MCI, whether they're single or multiple domain, the most likely cause is going to probably be Alzheimer's disease. Individuals who have either a single or a multiple non-amnestic, meaning they don't have a memory problem, but they've got problems in some other area like visual spatial abilities or attention or reasoning, these individuals who are non-amnestic are most likely, if they progress, to progress to other types of dementia, such as Lewy body or frontal temporal dementia.
So what does MCI look like on a day-to-day basis? These are some examples. So we won't go through all of them, just pick out a couple. But like the first one we talked about a little bit earlier, as we grow older especially, it's normal to momentarily blank on someone's name. Now, in Alzheimer's disease, at the other end of the spectrum, a person may not even remember your name and eventually not remember who you are. The person with MCI is frequently forgetting names. And part of the MCI is also a frequency issue. While in normal aging, every once in a while, we might blank on a name. In MCI, you're seeing a lot higher frequency of these kinds of problems. And while they can recall the name, it might take them a lot longer to recall the name. So another example is this driving example. So all of us, everybody, especially me, once in a while, forgets where to turn. But I can pick out a landmark. I can right myself very quickly and get myself going in the right direction. Well, the person with Alzheimer's at the other end of the continuum is disoriented to place and time, might not know where they are, getting lost in familiar places. Now, in between here in this middle, in this gray zone, the person with MCI might get disoriented for a short time. In the situation with the map, they might have more difficulty trying to trace their steps, find the landmark, figure out where they made the wrong turn, get themselves back in the right direction. So you can see how this is a progression from normal aging and a kind of a middle stage, a transitional stage to Alzheimer's disease. So how frequent or what is the prevalence of MCI? Well, it's interesting that research has shown it's similar in the sense that the older you get, the more at risk you are for developing MCI. And there was a study done a few years ago that showed that about 21% of everybody 71 and older has MCI. So basically, when you're 60 to 70, in the 60s, there's about a 1 to 3% prevalence. In the 70s, about a 16% prevalence. And then you can see as you're reaching the 80s, it's up to 30% and continues to increase in the oldest old. Actually, this is a really astounding fact that in 2008, it was estimated that there are 5.3 million people with MCI. And so think about that. If you have 5.3 million people with MCI, and just a little while earlier I said we had 5.2 million people with Alzheimer's disease, that's over 10 million people that are affected by significant cognitive impairment as they age. So I believe we talked about this in terms of the definition of dementia.
So if those individuals who do progress to dementia, it's often difficult for the doctors to tell where is the separation of MCI from dementia. It's not clearly marked because they sort of blend into each other, and sometimes we'll diagnose an individual with maybe late stage MCI when they really maybe are in the early stages of a dementia. So I think it's maybe illustrative of just to show how a person could progress through this stages. And I like to give an example of, say, a salesman at a car dealership who is in his earlier years, way back here, probably off the chart out here, he's functioning quite well. He's really good at sales. He knows like the top 40 clients who regularly come in and see him and make purchases. And he's functioning very well in his job and in his home. He's raising a family. But that individual may be starting to develop amyloid accumulation in the brain, and no symptoms are evident. As the amyloid is continuing to accumulate, he may enter this preclinical phase at some point. And let's say at some point as the brain is getting more and more damaged, he's starting to say, well, you know, doctor, my memory's not as good as it used to be. I can't remember the top 30 clients or 40 clients anymore. I have to consult a little notebook that reminds me of what they purchased last time, who their wife is, where they went to school. And my colleagues aren't really noticing anything. I mean, I'm still doing my job fine, but I know my memory is changing. And the doctor says, well, let's send you to a neuropsychologist and we'll get some testing done. And he goes to someone like myself at a clinic, and the scores are all normal. And so he's aware of something going on, yet he's still scoring in the normal range. Now, at some point, the individual may go into the MCI stage. And now the memory problems aren't just evident to him, but they're evident to a lot of other people, his colleagues, his family. And at this point, if we were to test him, he would probably score in the bottom 10% of his peers on, say, memory tests. He's still able to function. He can still stop at the store on the way home and buy the groceries. He can still pay his bills, yet there's a definite problem going on. And then if he slips into the dementia stage, at this point he may no longer be able to work. He may have had to take early retirement. Because he was making major mistakes at work, he was having trouble with his language, with his reasoning abilities, and so he's now essentially retired. And then this could progress over time into these other stages of mild, moderate, and severe.
So how long does this whole process take? The studies suggest that the process from MCI all the way through Alzheimer's disease to death can last up to a total of 16 years, with the MCI stage lasting anywhere from 3 to 8, and you can see the dementia stage lasting up to another 8 years. And certainly we've seen individuals that have had the disease even longer. So it's a long, long journey, as all of you in this room know. So let's talk about the primary causes of cognitive impairment. And as I said, dementia is an umbrella term, and not only have we talked about dementia having many causes, we've also talked about mild cognitive impairment having many different causes. So this is the way we think about the causes of dementia. There are 3 types. Now, there are about 10 to 15% of cases that are reversible, where the person can get better. And you can see some of the types of disorders and situations in which a person might get better: an infection, severe depression that might have cognitive impairment, metabolic problems, medication side effects. So out of all that list, which one do you think is the most common cause of cognitive impairment that can be reversed in older adults?
Medical problems.
Medications, because older adults take a lot of medications that have a side effect of concentration, thinking difficulties, confusion. So when someone has an acute change, an acute worsening of their cognitive problems, one of the things we want to think about is, do they start a new medication that might be contributing? So as I said, this accounts for about 10 to 15%. Now, a second type of dementias are non-progressive. So we hear a lot in the news these days about traumatic brain injury. And we hear about football players who have traumatic brain injury who later develop dementia. But when we talk about non-progressive, I think about a person who used to be at Alzheimer's Family Services Center that was in a car accident when she was in her 20s and had significant injury to her brain, and she just remained stable, right? So she had an insult to her brain, and she lost some of her intellectual ability, but her cognitive situation didn't progress, it didn't decline. She remained stable over time. So that's what we mean by non-progressive. And a single stroke might cause that kind of non-progressive, stable change as well. Far and away, the most of dementias are progressive. In fact, the progressive dementias account for about 85 to 90% of all dementias, and Alzheimer's disease is the most common one. Today, we're going to talk specifically about the two other very common causes of dementia with Lewy bodies, and in particular frontotemporal dementia. So there's also other causes of cognitive impairment, and these are some medical causes, and I just wanted to point out couple very significant. And since a lot of older adults have hypertension, individuals with hypertension over 60, age 60% prevalence of cognitive impairment. Similarly, sleep apnea, over age 60, 42% have some cognitive impairment, and also diabetes, another significant one, 23%, and coronary heart disease, 31%, experience some cognitive impairment. So again, if you have concerns about memory, the most important thing is to go into the doctor to sort out what in the world is going on medically, psychologically, cognitively, to see what the cause of the problem is. And some of these are very treatable. Hypertension, sleep apnea is treatable. So we want to address and identify conditions that can be treated as well.
So if you put everybody who has a dementia into this pie, what you would find is that, and these are the percentages for people in their probably 65 until maybe their late 80s or 90s. But if you looked at that age group and everybody who had a dementia, the majority would have dementia due to Alzheimer's disease. So Alzheimer's disease probably accounts for about 55% of all dementia. Vascular disease, this would be poor blood flow to the brain or strokes probably accounts for somewhere around 15, maybe 20%. And then Lewy body is either the second or the third most common cause of dementia, accounting for somewhere around 15 to 20% as well. And then the other causes, about 10%, are due to a lot of other disorders such as frontal temporal dementia, alcoholism, head injury, Parkinson's dementia, etc. If you look at people over the age of 90, I think the causes of dementia are probably quite different, where maybe vascular dementia or vascular causes is playing a much bigger role than when you look at people in their 60s and 70s.
So do any of you know who this is? Uh-huh. That's right. That's Dr. Alzheimer, a German neuropsychiatrist who was the first one to identify Alzheimer's disease in this woman. And do any of you happen to know what her name is? Yeah, Augusta Dieter. It's sad that this is the only picture that we have of her when she had Alzheimer's disease, and we don't know what she looked like or what her interests were, or see her in a different perspective. And I think it's interesting, from the very first picture that we have of someone with Alzheimer's disease, it creates a very stigmatizing kind of image of the disease because she's so impaired at this point. But she was identified actually at age 51 in about 1901 when her husband, Carl, took her to the sanitarium where Dr. Alzheimer was working, and she was showing some really unusual symptoms. She was, as the slide indicates there, she was having a lot of cognitive problems. She was also doing things like storing mail under her bed and stashing things around the apartment. She was accusing her husband of having an affair and neglecting all her housework, and that was her primary role as a wife. She was wandering out in the street. So many of the symptoms we associate with Alzheimer's disease she was exhibiting. Well, Dr. Alzheimer autopsied her brain at death in 1906, and he then found these plaques and tangles. He was the first one, actually. There was a new staining technique that allowed him to actually see the plaques for the very first time. As you can see there, originally Augusta was only 51 when that was, when she came to the sanitarium with her symptoms, and it was thought that originally, based on this first case, that Alzheimer's was a rare condition. But in the mid-1970s, it was recognized after some research by investigators named Blessed, Tomlinson, and Roth that we were doing a lot of misdiagnosis. They looked at the brains of people who had been diagnosed with arteriosclerosis, and they found that over half of them had these plaques and tangles that were associated with Alzheimer's disease. So what are the warning signs of Alzheimer's disease? What are the things that you should watch of and should be of concern to you?
Well, we've been talking about some of the memory changes, and the memory changes in the majority of Alzheimer's patients are the first and most prominent and dominant symptom that you'll see. Some Alzheimer's patients can have initial symptoms that are non-memory. They can have, say, visual spatial difficulties or language difficulties, but the majority of them will come in with a memory problem. And these could include everything from missing appointments to difficulty remembering names, which we all have, forgetting to pay bills, etc. So the memory loss is typically the first and most prominent symptom that we see in the majority of Alzheimer's patients.
And while that's true, it's not always the first symptom. Sometimes personality changes and other symptoms precede the memory problems, but a couple of other really common symptoms that occur or warning signs are if the person's having difficulty with planning or problem solving, doing things that are very familiar to them, like cooking a particular recipe and having more difficulty putting that recipe together and having it all prepared on time. As you can see, difficulty concentrating and also notably being able to do something just as well as they used to do it, but having to take a lot longer time to complete the task. It takes a lot more effort for people with Alzheimer's disease to do things. Difficulty completing tasks at home or with procedures, so oftentimes difficulties with managing the checkbook or some kind of difficulties with finance are seen early, as well as difficulty with procedures. Again, things that the person would know how to do all the time. So Malcolm's in charge of the remote at home, and I still have a hard time with it. So you can't judge whether I have Alzheimer's disease based on whether I can use the remote. But if I stopped being able to use the microwave or was having difficulties using the microwave, you start to wonder, well, what's going on here? Because I do that all the time, right? So the next one, a few more.
There's also changes in the concept of time and also disorientation to place. Usually the earlier symptoms are problems with time where the person will not know the date or the day of the week or even the year. Now as we get older, particularly when we're retired, we're not necessarily going to be aware of what date of the month it is, but usually we're able to sort of figure it out ourselves if we actually had to. But with Alzheimer's disease, it's not unusual that they don't even know the correct season, the month, or even the year. In addition to the disorientation, you'll often see changes in their visual spatial abilities. And one of the early signs might be difficulties with judging distance. So, and also judging like the distance or speed of an oncoming car. So things like getting into accidents may be due to visual spatial problems. They may also be having difficulty in getting lost. So even driving familiar locations, they might get confused about where they are.
All right, I think you were going to do the next one as well.
Oh, there's also language changes. The typical Alzheimer's patient, the major language changes you see are difficulties with what's called anomia, or naming of objects. And a lot of times Alzheimer's patients may call things by a related but incorrect word. So for example, they would call like a rhinoceros a hippopotamus, or they'd call a picture of a pelican a duck. So they can have word finding difficulties. They also have difficulties finding the right words to say in conversations. So oftentimes families might see the person becoming quieter and less talkative. They don't initiate conversation as much. They may respond to your questions, but they're not the ones sort of initiating or leading the discussion anymore. And also, they can be misplacing objects around the house. That's also very frequent. So if they were in charge of the bills, now all of a sudden, all the bills are misplaced and they're turning up in weird places around the house.
So we also want to mention that poor judgment is something that's a warning sign. And you know, we've seen families where the person with the cognitive impairment makes a bad financial decision, and the family or the couple loses their life saving. Another way that poor judgment comes out or might come out is inattention to one's personal hygiene or grooming. As Malcolm also already mentioned, you can see individuals withdraw, and when an older adult withdraws, we want to pay attention to that, because it could be because they're having some cognitive changes, could be because they're depressed, but this tendency to withdraw, socially isolate oneself, avoid participation in activities. Again, if there's cognitive impairment, that's often because it's become too hard. So that's a red flag we want to attend to. Additionally, we want to, along the same lines, attend to some changes in mood and personality. The person just seems to be behaving a bit differently, and some things we might see early on in this category are irritability, suspiciousness, some depression, as you can see on the slide. And again, wanting to be in a familiar place where they're comfortable and getting very anxious and agitated when they're outside of that comfort zone. So let's talk about diagnosis, and Malcolm, you should be aware it's 6:15.
Okay. That's a warning to.
That's a warning that we have gotten a little over halfway through, and we have 45 minutes because I'm the timekeeper of the couple.
Well, this slide is looking at how good are doctors at identifying Alzheimer's disease and even mild cognitive impairment in their patients. And in general, the studies are not very encouraging. Primary care physicians in a routine office visit tend to miss about 7 out of 10 patients who have moderate to severe dementia. Not just mild dementia, but moderate to severe. And about 9 out of 10 primary care doctors are missing patients with mild cognitive impairment and mild dementia. So they're really not able to pick up these changes until the person is really quite well advanced into their disorder. And maybe that's not surprising. I mean, a lot of doctors in primary care offices, they have limited time to see a patient. You know, if someone, Mr. Smith comes in, they'll say, well, how are you doing and what can I do for you? And Mr. Smith, who's got dementia, might say, well, I want to renew my medicines. And the doctor might say, well, how are you doing? And the person might have no knowledge of their own memory problems, say, oh, I'm doing fine. And so the doctor is busy trying to get their blood pressure, their temperature, get an idea of how they're doing. He doesn't have time to sort of do an in-depth assessment of their cognitive abilities.
And I think we all hope that that's going to improve with the new Medicare annual wellness visit that requires a cognitive screening, and the Alzheimer's Association is working with health plans locally to teach them how to screen appropriately. So hopefully we can improve that from what the research has shown in the past. Other reasons that Alzheimer's disease gets missed, though, is a lot of misperception. And the misperception, number one misperception, is it's just a part of normal aging. So we all said that, yeah, we all have cognitive changes as we age, but you have to be able to have a good radar in terms of when things are going over the line, and not just dismiss all cognitive problems. Oh, he's 82, of course he's going to have cognitive problems, okay? There are also a lot of cultural misconceptions, and we need to be sensitive to those here, especially in Southern California. Cultures in which the person is believed to be crazy or mentally ill, and where they might even be hidden in a part of the home or in the garage because of shame, a result of fate, or a karma, or God's punishment for my sins. These are all real things that people experience and believe that get in the way of their getting help. An imbalance in the energy, the yin and the yang, and then due to acculturation stress. And unfortunately, people really struggle to get the diagnosis, and you can see some statistics there that suggest that on average it takes over 2 years, and a family will see 2 or more doctors to figure out what in the world is wrong here. And unfortunately, during that time, the family or the couple might be arguing about what's wrong with the person, misunderstanding it, experiencing a lot of stress, and unfortunately, because they don't know what's going on, they don't get to take advantage of doing things like coming here and getting educated or finding services at the Alzheimer's Association. Diagnosis is often a big relief for the families to know that there's really a brain disease that's going on here, and there's a reason for my loved one's behaviors and changes, and it's the first step to getting some adequate coping skills. So as I said, when we don't diagnose folks effectively, they're missing the opportunity to take advantage of education, but they're also missing the opportunity to take advantage of treatment, because right now the medications that we have, that we'll talk about in June, are most effective in the earliest stages. And also, early identification allows the person to be part of their planning for the end of their life, because Alzheimer's disease is a life-shortening disease, and we want to give that person the opportunity to make their own personal choices and preferences. And we want to maximize their safety, as it says there.
So essentially, when a person comes in for a diagnostic workup, what the doctors are trying to do is they're going to try to classify the individual. Are they normal? Do they have mild cognitive impairment? Do they have a dementia? And if they have a dementia, well, what would be the likely cause? And also, we want to try to identify any sort of contributing factors. So for example, do they have a problem with sleep apnea or depression or thyroid disorders that could be worsening their cognitive abilities? So to do that, you need to really do a comprehensive evaluation. And this is probably one of the reasons why the disease and disorders are missed so much in primary care, in that doctors don't have the time or the skills to do all of these different tests. And they include everything from a very comprehensive medical history to get an idea what's the problem, how did it start, what were the initial symptoms. You want to rule out through blood tests, you want to rule out things like metabolic disorders, interactions of medications, vitamin B12 deficiency, all of these things that could affect a person's cognitive functioning. You might get brain imaging. Now, in most diagnostic workups, you would typically use a structural scan like a CAT scan or an MRI. It's not that often you see a PET scan, which is a metabolic scan that looks at activity, glucose utilization in the brain. Those are not really part of the traditional workup. It's primarily either an MRI or CAT scan. And then there'd also be a neuropsychological evaluation where you're looking at what is the person's weaknesses and strengths in terms of their cognitive abilities, and also a neurological and physical exam to make sure there's nothing like Parkinson's disease or strokes or tumors that could potentially be causing a problem.
What are examples of metabolic?
Metabolic would be like a vitamin B12 deficiency. That's really quite common. Well, it's not that common, but a lot of older adults have a hard time sort of breaking down food and extracting the vitamin B12, and so they could develop a deficiency, and we know that that could affect a person's memory, and later on, if it's not corrected, neurological functioning. So it's a very complex puzzle. You need all of these pieces, and you need to put them together in order to sort of solve, well, what is going on. And even when we have a complete diagnostic workup, doctors, even at specialty clinics, are probably only about 90% or 95% correct when it comes to Alzheimer's disease. And we're probably a lot less accurate when it comes to identifying some of the lesser or more infrequently seen dementias, such as FTD, frontotemporal dementia, and Lewy body.
So a lot of people are uncertain what we mean by neuropsychological testing. So neuropsychological testing is designed to identify your cognitive strengths and weaknesses. So here's just a picture of Susan and Peter illustrating, who are in the back, illustrating a particular neuropsychological test in which Peter's being actually asked to place the blocks in the same pattern as is shown in the booklet. And so there are a lot of different paper and pencil tests to assess various abilities, as well as this one, which is designed to assess constructional, visual, spatial abilities. This helps us in a very practical way. Not only does it help us to diagnose the individual, but it helps us in a very practical way to help the caregivers understand what the person can and can't do in everyday life and how to best support the person.
These are just a couple of images along the lower portion, sort of illustrating an MRI scan. And what you're looking at is you're looking at the brain where we sort of sliced horizontally, probably about midway through the brain. This would be the front, the person's face would be here, and this is the back of the head. And this is a normal brain scan, and this is that lateral ventricle, the one that has this cerebral spinal fluid. It's created here. But what you can see is the gray is representing cells or neurons, and the white is fluid. And the brain has a very convoluted surface, and the fluid is sort of lying in these little hills and valleys. This is in a sort of similar aged individual who has early Alzheimer's disease. And you can see along the sides of the brain, which would be the temporal lobes, a greater amount of white, which would indicate more fluid is sort of replacing those brain cells. So we've got evidence of atrophy or shrinkage in the temporal lobes, and also some in the parietal lobes back here. This is if you go back one.
Oh, sorry.
This is a view of the brain. It's called a coronal view, where you're looking straight ahead at the person, and now you're going to slice the brain sort of like a loaf of bread going from the front to the back. And this is about midway through the brain. So the person's ears would be here, and you're looking at them straight ahead. And this area that looks like a cauliflower leaf is actually a cross-section of the temporal lobe. And we're looking at this area which is marked with the little arrow. This is the hippocampus that we talked about earlier. And in this normal brain, you can see the hippocampus fills these two areas in the middle temporal lobe on both sides quite nicely. And if you would look at a person with Alzheimer's disease, in the next slide, this is going just that section of the temporal lobe. Here's our cauliflower leaf of the temporal lobe. This is the hippocampus in the normal. In someone who's mild, now we're starting to see some shrinkage. This is moderate stage, and then in the very severe stages, most of the hippocampus is shrunken away and atrophied.
So just briefly, in the interests of time, I want to clarify the difference between probable and possible and definite Alzheimer's disease. If you've come through the UCI Mind Clinic, you may have gotten a diagnosis of probable or possible Alzheimer's disease. And really the main point here, probable Alzheimer's disease, all the assessments have been done that Malcolm described, and the doctors can find no other possible cause for the cognitive impairment. That diagnosis is probable Alzheimer's disease. In possible Alzheimer's disease, the doctors have done the assessment, and there's a possibility that there's a second issue that's contributing, or there's presence of a second issue. So you might see vascular changes in the brain, evidence of small strokes as a secondary cause. So that's why it's considered possible Alzheimer's disease. And right now, we still don't know if it's definite Alzheimer's disease until autopsy, at which time the pathologist can open the brain and look and actually counts the plaques and tangles that are in the brain. So we're going to talk just a bit about biomarkers, and this is a cartoon image of the brain.
And what it's really showing is this accumulation of beta amyloid, how it starts in the temporal lobes in someone who's got the preclinical and MCI, and then over time, these plaques and the tangles with the beta amyloid and tau will eventually spread throughout the rest of the temporal lobe and into the parietal lobe at the back of the brain and the frontal lobes at the front. And then eventually in the late stages, these plaques and tangles will be distributed pretty much throughout the brain, with the greatest concentration still in the temporal lobe.
So do you want me to talk about the peanut butter test or not?
We'll hold off on the peanut butter test.
Oh, okay. The peanut butter sniff test. That was recently in research, but we can talk about that later.
So one of the new developments in the last few years is an amyloid imaging technique, which actually allows us to see the amyloid accumulation in the brain in a living person. Now before, you could only really see it when you looked at the brain at autopsy in someone who's been deceased. And so this is a radioactive tracer that's injected into the individual who's in the scanning, and The amyloid, for example, these are those plaques and tangles. We're actually not measuring tangles, we're just measuring sort of an accumulation or a grouping of amyloid. But it shows up in these bright red areas. And this is someone with Alzheimer's disease. This is sort of looking down. This is the front of the brain, the back. You can see the amyloid is distributed pretty much throughout the brain. This is a view of the frontal lobes, and this is looking straight ahead. And you can see the amyloid is in many areas throughout the brain. And this is a normal adult, and you can see very little or no red. So this individual normally shows no amyloid. So this Amyvid, it's called an Amyvid scan. It was approved by the FDA in 2012. And you would think, well, this is really a big, remarkable advance, and maybe all doctors should be using this. Well, the Centers for Medicare and Medicaid Services decided not really to approve this scan for general use. They don't cover the cost of the scan. The scan is about $4,000 to $5,000 if you were to get it yourself. Most third-party payers' insurance will not cover it. And the reason for that is, although it's very helpful for picking up amyloid, there's a concern in that in this situation, this is sort of the idealized situation you would like to see, where a normal adult shows virtually none of this red. Someone with MCI, it's not showing up very clearly, but there's some red here and in the temporal lobe. And someone with Alzheimer's disease, there's quite a bit of red for the amyloid. And so you would like to see going from sort of no amyloid to intermediate to extensive amyloid. But unfortunately, that isn't what really happens in real life. When you look at real life, what you find is some normal adults can show actually extensive amounts of amyloid in their brain. So this is a normal adult with low levels of amyloid, and this is another normal adult who's showing very high levels of amyloid in their brain. This individual who's a normal adult, actually their brain doesn't look that much different from someone who has Alzheimer's disease. And so it's because of that reason, the fact that in normal adults, they can also show amyloid, that they didn't want doctors just suddenly to say, well, let's not do all of this comprehensive workup. Let's just do an Amyvid scan and we can tell you yes or no, you're at risk for developing Alzheimer's disease. So we know that probably 25 to 35%, or roughly a quarter to a third of healthy normal adults can show amyloid in the brain. About 60% of those with MCI are likely to show amyloid and be progressors into dementia, and about 90% of Alzheimer's patients show amyloid. But it's interesting that even in 90%, so not all Alzheimer's patients show amyloid accumulation.
So what we've really talked about, to summarize, is that over the past decade particularly, we've moved the arrow back to where we're now working on diagnosing Alzheimer's disease in these preclinical stages where there are no symptoms, but there are biomarker changes. And Malcolm just spoke to you about that relative to amyloid imaging. We used to, when Malcolm and I first entered the field about 30 years ago, we were diagnosing folks way back there in the moderate to severe stages of dementia. So now we've gotten better at identifying folks early, but we still need to work on those treatments, and hopefully we'll merge so that we're treating earlier and we're getting more benefit from the treatment. So we're going to shift now in the next remaining minutes, 25 minutes, to talk about two other types of dementia. Dementia with Lewy bodies, and this is Dr. Friedrich Lewy, who in 1912 first described the formation that's called a Lewy body in a Parkinson's disease patient. What's really interesting about this is that Lewy bodies weren't associated with dementia until the 1960s or 70s. And so we're going to show you now again and remind you that dementia with Lewy bodies is the second most common cause of dementia, and that here we have pictures of Lewy bodies right here and right there. And they are in, they have a central core and a halo around them, and they're in the deeper areas of the brain. One of the areas being called the substantia nigra, sorry. And they can be seen both in patients with Parkinson's disease and individuals with Lewy body dementia. And so there's just a few facts about Lewy body disease. I've already mentioned that's the second or third. You know, there's some variation in that belief of where it ranks. But most of them are over age 65, and over 2/3 are male. Also, the duration of Lewy body dementia is shorter, an average of about 7.5 years. So oftentimes, Lewy body dementia is actually diagnosed as Parkinson's disease because of some of the similarities we're going to talk about here for a moment.
When we talk about Lewy body, there's 3 core features that typically doctors would be looking for. The core features are, first, you have to have the presence of dementia, but then the other features that are very common that are sort of really red flags when you see them that might suggest Lewy body are the presence of visual hallucinations, cognitive fluctuations, and we'll talk about those 2 things separately, but also the presence of Parkinsonian or Parkinson-like symptoms. And these typically include a slowness of movement, or what's called bradykinesia, where the person is slower in their movements, they're walking slower, they also have increased rigidity. So when you're like helping a person with Lewy body put their hand into a sleeve of a jacket, you might notice a stiffness and a rigidity in their limb. They might not notice it, but this rigidity or stiffness is another characteristic. Unlike Parkinson's disease, Lewy body patients, it's unusual to see the resting tremor that you see pretty much classic in most Parkinson's disease patients. The other key features are the ones we look at are the hallucinations and the fluctuations. And the fluctuations, they're seen in probably 9 out of 10 Lewy body patients. And they're hard to measure. They may include things such as the person will have periods of time where they're more confused. They often will sort of zone out. Like if you're talking with them, families report, you know, I'm talking to my parent, and they sort of have they sort of zone out on me. It's like they're looking through me and they're not really hearing what I'm saying. I have that a lot with Cordula.
Thanks.
So you can have this staring into space. You also have fluctuations in the ability to use tools. So for example, sometimes families will say, you know, my dad, he can work the remote fine, and he's really doing it perfectly, and then an hour later he's very confused and can't figure out how to use it. But if I wait 20 minutes, another hour, he'll be back using it fine. Or my mother, she can't use the microwave sometimes, but other times she's perfect at using it. So you see these fluctuations in awareness and attention, but also in the ability to utilize tools. The other feature are presence of very detailed, recurrent visual hallucinations. And these are well-formed, meaning they're not just, oh, did I see somebody walk by here? But they're actually seeing a person, say, in the room, and they can describe what they're wearing and what they look like in great detail, even though the person obviously isn't there. The hallucinations typically involve people, animals, or insects. The individual with Lewy body may be quite aware that they're having a hallucination, and they know that this person they're seeing standing there that they can describe quite accurately that that's not a real person. One of the first Lewy body patients I saw many years ago, the family told me that this individual almost every night saw this Quaker family come into her room. They were all dressed in sort of the dark clothes, and they would cut a hole in her closet and then take her clothing on coat hangers and pass them from one family member to the next on out the door. And she could describe to her daughter, what they were wearing and what they looked like, but obviously they were not there. We just more recently had a patient who was still working, and he had to take the Amtrak train from Orange County down to San Diego County. And one day he came home and told his wife that he really liked the jazz band. And the wife was surprised. She thought, oh, Amtrak, they're trying to increase their business. And he said, oh yeah, they're like the Dukes of Dixieland. They're in striped shirts, straw hats, banjos, and they were playing this music. And so one time, he kept repeating this story, and so one time she had a chance to go down with him to San Diego, and he said, isn't the band just great today? And there was no band. And so this was really something that was very unusual, and so she brought him to the clinic. But these hallucinations are very common. They're common particularly early in the disease. Like in that case of the gentleman, he was still working, and he had these. There's also things that are called supportive features. So if you have two of those three core features, the Parkinson, the visual hallucinations, or the fluctuations, if you have two of those three, you have what's called probable Lewy body dementia. You can have possible Lewy body dementia where you have one of the three and two of these supportive features. And these can include feelings of lightheadedness, repeated falling, a marked hypersensitivity to antipsychotic drugs, which we'll talk about when we talk about medication. They can have systemized delusions, hallucinations in other modalities, like the gentleman had auditory hallucinations to go along with the visual of the band. But also something called REM, sleep behavior disorder. And this is a disorder where normally when we're asleep, we lose our muscle tone. So we can't act out our dreams. But in patients who have Parkinson's disease and Lewy body disease, it's quite common to see this. Probably about 50% of patients show this, where they don't lose their muscle tone and they can actually physically act out their dreams while they're asleep. So they may be frailing their arms, shouting, talking. We actually had one patient who injured himself leaping out of the bed when he was totally asleep, knocking over the lamp and the end table. And he told his wife, well, he was dreaming he was jumping for a basketball. And he just physically jumped out of the bed when he was asleep. So these REM sleep behaviors are probably about 300 times more common in Lewy body and Parkinson's than they are in Alzheimer's disease. Another feature we look for if you were to do a regular SPECT scan or a PET scan is that in Lewy body patients, they actually show more reductions in activity in the back of the brain in the parietal and the occipital lobes. They show less activity there than do patients with Alzheimer's. And the amount of reduction in activity is also correlated with the frequency of visual hallucinations. Lewy body patients also do better on tests of memory and attention than do Alzheimer's, so they have less changes in their temporal lobes than do Alzheimer's patients.
So we're going to talk about FTD, and this is Dr. Arnold Pick, who identified FTD in 1892. So remember, Dr. Alzheimer identified Alzheimer's disease in 1906, 1907. So FTD was actually identified earlier in a 71-year-old man with a 3-year history of progressive language difficulty. So that man would have today received a diagnosis of semantic dementia, which is a type of FTD. So you can see that FTD accounts for a smaller percentage of dementias, but it's very significant, and we talk about it because the most common or behavioral variant of FTD is very debilitating to the patients and is very stressful for the families. So here are just a few facts about FTD. You can see that in this case, FTD is more common in people who are less than 65 years old. Actually, the average age of onset is between 52 and 56. And for people 45 to 64, there's approximately one person with FTD for every person with Alzheimer's disease, because Alzheimer's disease is less frequent in younger adults. So FTD represents 20% of young onset dementias and 5% of late onset dementias after age 65.
This is just an illustration of someone with FTD at time of autopsy. And this is looking at the brain. This is the back. This is the cerebellum that's sort of at the base of the skull that's involved in movement coordination. But this is the front of the brain. And these are the gyri, or the hills and the valleys. And notice this is sort of what a normal gyrus should look like, the normal hill. Look at how shrunken and shriveled these gyri or hills are in the frontal lobe. So this atrophy or shrinkage of the frontal lobe and the anterior or front part of the temporal lobe are sort of classic signs that you see in frontal temporal dementia, particularly the behavioral variant. And these are some brain scans. This is a normal brain. Again, we're sort of looking down from the top, slicing horizontally. So the person's face would be up here, and this is the back of the head, and their ears along the side. So it's like you're standing above them looking down. And this is an FTD patient, and you can see the black, again, is the fluid, and the sort of gray and white are the brain cells. And you can see how shrunken this frontal region is and the anterior temporal lobes. Compare that to someone with Alzheimer's disease, where their frontal lobe is actually looking pretty good, but we're seeing shrinkage in the temporal lobes. This is a SPECT scan which looks at blood flow, and by blood flow it's sort of analogous to activity or metabolism. And this is a normal brain looking horizontally, similar to here, and the good blood flow shows up as white and red. So this is that ventricle in the middle, and so you should see a nice mantle of red and white all the way around the brain. This is what you see in frontal temporal dementia when someone gets into the middle stages, and you can see the yellow represents about a 50% or more reduction in blood flow compared to the red, and you can see a marked reduction in the frontal lobes and anterior temporal. Compare that to Alzheimer's, where you see mainly temporal and parietal deficiencies or loss of blood flow and activity, with relatively good frontal lobe activity similar to what we see in our normal adult. So you can use scans, both structural and metabolic, to help you identify these disorders, but these changes may not occur at the very beginning of the disorder. In fact, many times you might have an MRI or a SPECT scan or a PET scan come back with that looks a normal brain, even though later, and we might diagnose them with one of these diseases. There's also different biomarkers. We've talked about the biomarkers for Alzheimer's being the plaques and the tangles with amyloid and tau. In Lewy body, it's alpha-synuclein and ubiquitin, that are involved with the Lewy bodies. And in frontal temporal dementia and Pick's disease, which is a type of frontal temporal dementia, what they do is they show sort of a ballooning out of cells. The cells have sort of like ballooned out, puffed out. These are called Pick bodies. And also you have, if you were to slice the brain and just look at the brain tissue, it has what's called a spongiform appearance. And by spongiform, it's like if you sliced a sponge and looked at it, you would see all of these air holes or air pockets. And that's what the tissue of someone with frontotemporal dementia tends to look like. It has this spongiform appearance.
Yeah, we have 10 minutes left.
Okay, I think we'll skip the language variant and we'll just go to the next slide and
We're going to talk about,
well, just, yeah, on this one.
This one, right.
There is a language variant of frontotemporal dementia, which is very interesting, and in fact, you could almost have a presentation on those alone. But this is where there's language difficulties that are the first symptoms that you see. But the most common form of frontotemporal dementia is where there's behavioral changes. And so given our limited time, we're going to focus on the behavioral change one.
So we just wanted to briefly describe 10 of the most common symptoms of FTD, again, the behavioral form of FTD. And so you can see, and that makes sense given what you saw in the brain, that memory is relatively spared. Malcolm just showed you a moment ago how the temporal lobe is less affected early on in FTD, and the frontal lobe was where quite a bit of atrophy occurred. So consistent, we see more spared memory and spatial abilities. So there was an example of a patient who could bicycle for miles and never got lost and could tell family members where to turn to get to locations, even when almost mute and could rarely speak. So there's also loss of insight and judgment, and some of the ways you see that might be through impulsive buying, impulsive decision making, like the slide says. You see inability to appreciate the consequences of behavior. You also see a lot of socially inappropriate behavior. Long years ago, I had a patient with FTD who would actually get up on a table like this and start dancing. So inappropriate contact with others, as the slide. You see dietary changes, especially what we call dietary hyperactivity, which is a nice way of saying that they start to crave and search for food and will binge, and particularly on sweets. So the same patient I was mentioning to you, the woman from many years ago, we had a cake at our center and she just put her hand right in the cake. So you see those kinds of behaviors. Changes in sexual behavior, so there might be more demands for sexual contact or initiating inappropriate sexual contact with others. Again, the disinhibition. Stereotype behaviors, so stereotype, repetitive, both movements and language. So you might see things like repetitive tapping, hand clapping. Verbally, you might hear someone humming or counting aloud, and facial movements as well as in activities. You can see this kind of repetitiveness and stereotypical behavior. They become less spontaneous over time, more socially withdrawn, lose interest in others.
Just to give you an example of that sort of compulsive stereotype behavior, we had a patient who had FTD, and when the wife brought him in, we asked how he sort of occupies himself, and she said he had 10,000 CDs, and he was essentially going to the music store and buying these CDs all the time. And I asked him, well, his favorite groups, and he said ABBA was his favorite group. And I said, well, how many CDs do you have? And the wife said, well, he's got like 10 CDs that are identical, and it's just that he sees it and he wants it, and so it doesn't matter that he's got 9 other copies, he wants that one. So you can have this sort of compulsive, repetitive behaviors that are very common in FTD. Sorry.
So, also, there's this emotional blunting that can occur, and one of the things that's really difficult for families is that there's a loss of empathy. So in people with Alzheimer's disease, even though they lose the ability to communicate, there's often emotional connection you can make. But with a person with FTD, you'll see their inability to communicate, but also to emotionally connect with another person. So you can see also rapid fluctuations between different emotions and inappropriate emotions like laughing at things that just aren't funny. A lot of restlessness, an inability to sit still, pacing, and finally speech disturbances, which is repeatedly saying the same words, singing the same song. They can be constantly talkative or also mute. So, sure, but I think that some of these, so for example, in Alzheimer's disease, you wouldn't see the same kind of disinhibition. It's much less frequent in Alzheimer's disease. You might see disinhibition, but when you see that kind of disinhibition, it's a red flag that it might be frontotemporal dementia. Sure, you see loss of interest in all people with dementia, but that is a characteristic of frontotemporal dementia as well. You don't see, in Alzheimer's disease, for example, you won't see the repetitive kind of stereotypical behavior. Like we had a participant at the center that hummed. All they did was hum and hum and hum the same tune over again. You don't see that in Alzheimer's disease. So, you know, there are some characteristics here that are very different from what the behaviors that the behaviors or challenging behaviors you see in Alzheimer's disease. So I think we're at the end. That's a chart.
Just to quickly summarize, we put a chart there. So in FTD, the behavioral and personality changes are present. They're the earliest symptoms. They're often present for about 3 years before, say, some of the cognitive changes occur. So it's early personality changes you're looking for. You could have changes in speech, their production of speech. They can eventually go to where they're totally mute. Visual spatial skills, unlike someone with Alzheimer's disease or Lewy body disease, those are actually quite preserved in frontotemporal patients. Memory is generally much better in an FTD patient than it is in Alzheimer's disease. Lewy body patients, their memory is better than in Alzheimer's. The motivation, typically in Alzheimer's disease, when you try to test them, their social skills are intact. They want to do the best they can. With FTD, oftentimes it's very hard to test them because they don't care two hoots what you think of them, and they don't care to put any effort into doing the tasks or being cooperative or even sociable with you. So there's this marked lack of concern, inappropriateness, disinhibition. In Lewy body, it's more similar to Alzheimer's in that the social skills is retained, as well as often these individuals retain some insight. So by looking at the different features of the disease, you can get some idea, you know, based on the symptom pattern, what type of disorder you might be dealing with. And then you add that to all of the other tests, the imaging, the blood work, et cetera, and you sort of come up with a diagnosis.
So it's right at 7 o'clock, but we'll maybe continue for about 5 minutes to see if anybody has any questions. Before we take any questions, I'd just like to remind you all to complete your evaluation forms. They're very important to Malcolm and me, and we really value your feedback about what you liked, what you didn't like, what we could do better. So please give us that feedback. And while we're doing that, does anybody have a question?
Turn up the lights more next time, will you?
Marcelo, did you hear that?
Turn them up more?
Yes, up more. So yes, that has been communicated. Question in the back there?
Now that you know that beta amyloid is one of the precursors to Alzheimer's disease, what are you doing to stop it or maybe prevent it right now? Or what can caregivers do to stop it or prevent it?
Well, interesting, that's, there is a clinical trial that's just starting that is using, it's called Expedition 3, that is trying to essentially go in and remove the beta amyloid from the brain. And we'll talk about this next time when we talk about some of the recent developments. It's from Eli Lilly. It's a clinical trial where they're essentially trying to go in and remove the amyloid with the goal of maybe helping to slow down or change the progression of the disease. There's also a study that is just in the early stages of getting starting. It's called the A4 study, which is this is a study that's going to be done in Canada, the US, Europe, and I believe Australia. And what it's doing, it's looking at individuals who are in that asymptomatic stage of the disease, where there's no cognitive really problems, but there's an accumulation of beta amyloid, and they're going to give the same medication that they're doing in the Expedition 3 study to these individuals with the goal or the hope that it might help to remove the amyloid that's starting. So I think some of the future trials are going to see if we can alter what's going on in the brain, and maybe by doing that actually have an opportunity to slow down the progression. Did you want to know about
Go ahead.
Has the rate of Alzheimer's, like in so many per thousand, has that actually increased for a given population, like the whites or the Hispanics or those with education or those without education? Is the rate actually increasing in number per thousand?
I don't think the prevalence or the rate, the incidence or the rate, I don't think that is changing. I think people are better at diagnosing it. There's less misdiagnosis. So as Cordula said, prior to the mid-1970s, most cases of dementia were attributed to vascular causes. And it was only about 1975 that they realized that was a major medical misdiagnosis, and that most cases were probably due to Alzheimer's. But I think with the aging population, more people living into the older age groups, we're seeing more and more cases simply because of that aging or the graying of the population.
There's some indication, at least in a couple of studies, that the prevalence might be going down slightly in the future, and that's because people are paying more attention to what they can do to reduce their risk. So all the lifestyle changes that people are adopting. So we'll be talking about that in the November presentation.
Do you know anything about the rate of this in other countries? For example, the Okinawan live longer than other people. Do they have a lower rate than we do, for example?
There are some studies that suggest, like in India, for example, they may have a lower percentage of their older adults affected. But I think the general idea is that Alzheimer's disease cuts across all countries and all boundaries. And the biggest risk factors that you see in Japan or China or India or United States is age. And so some of the difficulty in looking at the percentage of people in these other countries is that, just for example, back about 1980s, mainland China said they didn't have Alzheimer's disease. And they had a lot of older people who were confused, but they didn't have Alzheimer's disease. And some researchers from UC San Diego went over there and they actually did some testing, and they found the same percentage of older adults there have Alzheimer's disease as the United States. So in India also, if you're dealing with a very, particularly in the less developed parts of the country, you may not be able to pick up Alzheimer's disease very easily. For most older adults in the United States, they have to keep track of their bills, they have to use the communication devices, the phone, the cell phone, computers, they have to drive. Maybe in a rural place in India, the grandfather or grandmother isn't doing any of those things. Those are all taken over by other family members, and maybe the grandparents, their task is just to watch the grandchildren and maybe help with meal preparation. And those wouldn't necessarily pick up a subtle change that we might see in a more Western culture. So I think there may be some underestimating of the numbers of cases in some of these less developed countries simply because they're sort of going under the radar and not being detected.
Okay, well, we're going to wrap it up for now because I see that people are having to go, but Malcolm and I will be here, so if you would like to ask any question, you can just come and walk up. Thank you so much for your attention tonight, and we hope that you have found this helpful for yourselves.